everybody's ready, we're going to try it. We're going to try it this way and see how we go. So, shall we start with everybody introducing themselves? How about that? Does that sound like a plan? So,
yep.
Oh, sorry, Terry.
No, good plan.
Great. So, hi everybody, I'm Gina Sargeant, Head of Therapies at the RUH in Bath. Long-term colleague and friend of Liz, and Kerry's with me. Both, we've lived a bit of a home first art journey here, which we're happy to chat about. Liz, would you like to describe yourself, or would you trust me to do that for you?
Do it for me, Gina.
Okay, so I'm going to introduce Liz for you all. Liz is one of the senior clinicians with NHSI and previously ESIST, and the quickest describer is to say Liz is our queen of Home First. She supports us all with our new services when we get Home First off the ground, and so much more besides. So that's the two of us. I'm looking to see if a couple of the other Amit or others, would you like to introduce yourselves? Don't be shy. Come on, guys. Let's all chat. No, not yet? Okay. Well, what we'll do, we'll keep our eye on the chat box. I'm going to get Kerry to start us off, just giving a brief synopsis of our Home First journey here in the RUH, and go with prompts from that and conversation. Terry has got some conversational questions for us all to talk about Home First as well. So over to you, Kerry, to start with. Swap seats. I'll move out and Kerry's going to move in.
I might actually remove my mask. Good morning. I'm not sure who I'm talking to. My name's Kerry Hobson. I'm the clinical lead for Home First here at the RUH. So we started our Home First journey with support really from my she's within kicking distance, so I have to say nice things of Gina, but I think without Gina we wouldn't have got anywhere, because she had the bravery to take the step forward when we sort of had the ideas. And what we really wanted to do was just take people home when they were ready to leave hospital, rather than waiting for the care that was available for them in the community, because we could see people were staying in hospital a little bit longer than they really ought to. And I think we all know the effects of hospital deconditioning. So we started very gently with our colleagues in Wiltshire, literally sort of bridging the gap between when they could start and when we felt that this person should leave the hospital. So we started doing that, and we ran well, it wasn't supposed to be a project, was it, Gina? It ended up being a project. It ended up being a winter plan project, and we ran it for 4 months with really good outcomes. And the plan was either then to expand it or to stop. The expansion happened across the CCGs that we cover, but it actually happened with our community colleagues taking it on rather than us doing it. So we've ended up with a really good, robust Home First service that we kind of started from here. I always like to think we did at least start it from the acute side, but now our community colleagues are really much more in charge of what's happening with our patients out in the community. Does that kind of cover?
Oh, we have visual of Liz.
Hi, Liz.
Morning. Visual, but now we've lost the sound. So that's our Home First journey as we started it. Shall we go with one of the questions, Terry? Pick a question.
Right. I'd like to know from Liz, why was Home First needed? How did it start? Was it a broken system, or just nobody had ever thought of it before?
Great question. Liz, did you catch that? So yeah.
Say that again.
One more time, Terry. Sorry.
Okay, so Liz, I wanted to understand why Home First needed to be a thing. Did it need to be a thing because it was fixing a broken system, or was it never a thing before? So we bandied about discharge to assess and discharge planning, but Home First is different, isn't it?
A bit, Terry. So if I go back 25 years, when in what was then known as intermediate care emerged as a thing, that was supposed to enable people to go home sooner with support. It was supposed to be a joint service with social care, as described in, I think it was the NSF for older people in 2003. And fundamentally, we kind of have not managed to do it, because so much of the way we're trained, particularly as therapists, but many others, is to do all the belt and braces in hospital and check people are okay. But a few people back in the late 90s, early 2000s did discover that if they did more of that at home, they actually got better outcomes. Sadly, in those days, we weren't terribly good at writing things up, and we were too busy doing it. So some of the evidence got lost. Then we've had increasing evidence of deconditioning that occurs for older people when they're in hospital. So, yeah, I think Home First is an attempt to take the many attempts over 25 years to go, the best place for these people is at home. We need to stop doing assessments in the way we did them in hospital and do them in people's homes to ensure they have the best possible chance of remaining at home. Which, you need to be really creative, and some people might need 24-hour care for a week while you do it. But with the amount of living care that's now available from many national organisations, it doesn't even require your local home market. You can get people home. And now we've got the funding from the Treasury that helps places that wouldn't leap over the barriers, as Gina and others have done, to give some funding behind setting up new services to do it. But fundamentally, I think we've been putting too many people into long-term care too fast. There's massive variation across the country, and all older people should have, and it isn't just older people, but they are the primary numbers of this, need that opportunity to go back to their own home, which is where most of them want to be. Hence, Home First, I think, captures people's hearts and minds better than all the other phrases we've had in the past, Terry.
Well, I agree, Liz, and you talked about this is often associated just with older care, older people, but I want you to know that actually this whole philosophy and way of thinking has influenced huge areas of healthcare. So I'm a colorectal and stomach care nurse, and it really made me think about what was I doing keeping people in hospital following their surgery. How could I get them out quicker? How could I teach them at home? Could I do a home visit on the first day to actually reduce that person's hospital admission? So this whole thinking, Liz, has a much wider spread and influence. It has changed other people's thinking. So it's amazing, actually. Can I?
My son is a colorectal surgeon, and I've trained him well as well.
Yeah. Well, there we go. So obviously colorectal and stomach care healthcare professionals are more amenable to this kind of open thinking and transferring of learning. I've got one more question for Liz, if I may ask. So Home First is all about the person at the centre of their discharge decision. How have we really made this empowered patient actually being part of their treatment plan and their discharge plan? So how have we made it a reality rather than a tick box, Liz?
So I'm going to let Kerry answer that, because they were going to try and get a person who's experienced this on it, but I think Kerry has a number of journeys where you can describe how you've done that.
Perfect.
I'm happy to answer. I don't want to hog the camera there. I'm sure there are other people that have done similar things. Kerry, the first question that you asked, when you were saying about why did we do it in the first place, and why did sort of Liz help us to make these steps in the first place. What we discovered when we were taking people home, and it's not a surprise and we knew it was going to happen, was that people we thought had very high care needs when they're being assessed in the hospital actually don't have such high care needs at home. So the classic example that I always give is that somebody in hospital might struggle to get in and out of bed, because they're on a mattress and we're looking after their pressure areas and making sure they're safe. So in hospital, it looks like they need help in and out of bed. Actually, at home, their own bed is so familiar that they know exactly what they're doing. But often at home, they might have difficulty with the toilet. So in the hospital, we've got them in these lovely, enormous toilets with rails everywhere, and we don't see it's going to be a problem. Actually, at home, they've been hanging onto the radiator for the last 3 years. So that's quite a good example of going into somebody's home and finding out that it's not what you thought it was. And people are waiting in hospital for something that, you know, we do our best in hospital, but if you're not seeing somebody in their own environment, you really don't know what they can and can't do until you get them there. So that's why, you know, the whole discharge to assess thing, the whole doing the assessments at home is such a powerful way of supporting people. I think the other thing, and this is the answer to your second question, around empowering patients to make decisions, really the minute you are at home with somebody, the control is not really yours anymore anyway. You're in somebody else's home. People that work in the community are thinking, yeah, we know this, but if you never have had that opportunity to do it, the minute you're not in hospital and people aren't, you know, behaving themselves and doing what they have to do to be well looked after in hospital, you're in their home. Actually, it really is down to what they do and don't want to do. And it's what's important to me when you get in somebody's house is the thing you're then working on. So it is much more patient-centered because it has to be, because you're in their house. Does that sort of answer your question?
It does, but it makes me wonder how you manage the message to relatives, because it's a changing of philosophy, isn't it, really? Changing the thinking, my relative is better, I want them to stay a bit longer in hospital to convalesce, they're chucking my relative out too soon. It's this managing the message, which you obviously have really very successfully done, because this is presented as the best practice rather than pushing people out, it appears to me. But I can imagine managing the message can be potentially difficult at times.
I completely agree, Terry. I think that is the hardest bit of it. And it often isn't the patient, it often is the relatives around the patient that have concerns. Very often really well-founded concerns. It may be they have been doing lots of informal support anyway before the patient comes in, and they're very worried that nothing is going to happen and they're going to have to pick up the pieces again. And I think some people have had poor experiences in the past. We have to acknowledge that, you know, people get what they need, but they don't always get what they want. And sometimes the want and the need thing, that's where the difficulty happens. So I think it's about being very honest and saying, you know, we probably won't be doing the dusting and moving the doilies around, but something that you need help with, we will help you, and we will help you to get back to doing it yourself if that's what you would like to do, and that's within, you know, the limits of your disease, if you like, or frailty. But it is really difficult. I think it's probably one of the hardest things. When we were doing the active recovery team, when we were taking people home ourselves, I think it was easier, because if you're the person taking somebody home, they have a relationship with you and they know you and they will trust you. And if you say, I think it's okay to go home, let's have a look at your house tomorrow, it works much better. The system that we're in now works very well in that we have a bigger capacity, but we are handing over to other people. So the patient doesn't really know the person that's going to be meeting at the other end. And I think that's quite difficult. And we can reassure and help. In the ideal world, we'd all be one big lovely system and we all do all of it together, but that's quite tricky, and it's probably a few years away, but I'm sure Liz will have some ideas as to how we can do that, Liz.
So and I want to bring some of the others, but I think if we can move to a philosophy of, if they weren't really known well to the community before and the acute could take them home for absolutely the reason Kerry has described, that's what I'd want, because I'd want who I trusted. And then those that are really well known to the community should be pulling out. And I think we've probably got some examples. Are Alice and Moira on the call?
Alice is on the call.
Yeah.
Are you happy to talk a bit more about your process service?
Yeah, so in terms of where in Reading, what we did was we set up a early support discharge team. So we were the acute therapists taking patients home from the ward. So we Kerry was sort of saying, that relationship was already built because we knew the patients on the ward, and we would take them home and see. Obviously, the change in them was massive. They'd be using a frame in the hospital, and then when you get them home, they just leave the frame at the front door and walk straight through, because they've got things that they hold on to at home and those kind of things. And I think that's, in terms of the relatives as well, I think we would often try and meet the relatives when we took them home and make sure that they could see it for themselves as well, because I think that has a massive impact on how comfortable they feel.
Definitely. I think one of the things that we found here that was really interesting with both those models was, if you can get the relatives to trust and understand it, and that difference between being acutely unwell and actually continuing to recover at home rather than staying in hospital to recover, we were getting far more relatives volunteering to step into some of the care gap, doing some of that rehab and assessment with their relative themselves as well, and we saw that a real significant change. So when it works and the relatives, it really works, if that makes sense.
Yeah.
I don't know if you felt that and found that.
It's understanding the first few days are normally the hardest, I think, when the patient first gets home, and once you've got past the first, I don't know, 24 hours or 72 hours, things definitely tend to get better. And obviously there will be cases when things don't work out as well, but generally I think once they've got back into a routine of taking their medications and things like that, things are better, and it's so much better than them having been in hospital for that time. Even if we put the care in, they need time to settle in.
Absolutely, yeah, I would agree. Yeah, Emily, did you have something similar at Salisbury? Sorry, Liz.
No, I'm just saying many of these patients have got composite problems, so it's quite important to be able. They will take a while to settle because we destabilise them quite a lot.
True.
Hello.
Very. Hi, Emily. Is that you there?
Hello. Yeah, I think similar to Alice at Salisbury, and what Kerry was saying about when you very first started at Bath, having people in the acute that can meet the patient in the acute and take them home is really beneficial to reassuring the relatives. But it doesn't always have to be the same person in the acute. And I think what you're finding in Bath, and what our early supported discharge team are finding here, is that even if they are reassuring people that someone will meet you at home and assess you at home, and then the support will be tailored from that point onwards, that's massively reassuring. And actually I found it quite interesting changing roles and doing my new role is working with Parkinson's patients, who are some of the most difficult patients to discharge because their needs change so much depending on the environment. So our ESD team has definitely been taking a lot more Parkinson's patients home who look like they can't do anything in hospital and then abandon their sticks and walk through the park the next day at home. So
yeah,
I think without having the reassurance of the ESD team and Home First at the other end to assess them at home, it would be very difficult to discharge those patients, and they would end up in bed-based care in previous systems. But you need the assessment rather than just the care prescription.
Definitely. I think, interestingly, one of the things that we found, particularly in the recent weeks with the new legislation, or Liz's mantra, as we nicknamed it here, looking at the discharge pathways and the DPTL and the new way that we're measuring patients' criteria to reside in hospital and therefore a speedier discharge as possible, we found it a real help that consultants and other MDT colleagues understood the Home First pathway. Has anybody else, have you found that? We found that that's kind of fitted in quite well around the acute therapist role and the MDT role, to continue to prompt that. I'm going to get Kerry to describe it a little bit, because we've been working quite hard on that, and I think it's an interesting next Home First challenge for us all.
Wheeling again. I feel like the old lady that keep wheeling in and out. So yeah, we work kind of across systems. So the IUH faces both Wiltshire and Bath, North East Somerset, and South Gloss. So we actually get together on a Thursday morning, all of us, and talk about Home First. And the thing we really wanted to achieve, so in March, we did manage to meet in a room together. This is before lockdown happened. And the thing that we really wanted was to increase capacity for our Pathway 1 Home First patients. And we weren't quite sure how we were going to do that. And then this thing called COVID came along, and it really helped. It helped that happen quite a lot, not in the right ways, obviously, but because the push really is to get people home rather than another place that they can just wait to get better. It helps hugely. And I think getting people into the mindset of home really is the best place to go. Because I don't know, for those of you that work in acute hospitals, what we find is that sometimes somebody in ED or somebody on one of the admitting wards mentions the word community hospital or having a rest somewhere, and that is what the patient assumes is going to happen to them. So getting people into the idea that if somebody's come from their own home, you assume they're going to go home again unless something really major has happened to them. That's quite helpful. The other thing that I think that COVID did for us at the beginning is because there was sort of more capacity in the system, and because people were really being encouraged to get people home, barriers just disappeared for a while. So it was all about, I felt we worked much more cohesively together to help people get home. I think now things are changing again. I'm going to be really honest and say I think some of the barriers are coming back up again. And I think for in our area, I can only speak for me, but if people are needing quite large amounts of care and it's likely to be long-term amounts of care, I feel we're losing that kind of home first. I think we're almost going back to, well, they need QDS double ups. They're going to have to wait in hospital for it. And that's a bit disappointing. And that's the honest thing that I'm finding at the moment. So I don't know if anybody else is.
I think Phil mentioned it in the chat box that absolutely COVID reduced some of that red tape and made it as patient-centred as we could possibly make it for Home First. So as a system, it's a little bit frustrating that some of the old rules or restrictions have crept back in, but as always, we're going to challenge those in a positive way. There was a bit of a chat I saw about how are acute therapists managing the capacity for this. And Liz, if you're happy, I'll lead a little bit of a conversation about this because it's something I feel quite strongly about. We've worked quite hard at the RUH to really help all our acute teams really understand the Home First principles and be involved in Home First, whether it's working alongside the community colleagues or being part of Kerry's FAB system big room once a week. And I think that has led us to a position where now actually the therapist will go, do you know what? That patient needs just that little bit or that one-off thing. I'm just going to go and do it. I'm going to take them home and just do it. And that has really helped change that mindset. And I think it's fascinating the wording around some of the action cards and the prompts and some of the professional conversations that I've now seen coming from that, where some trusts are feeling, I think it's fair to say, a little bit defensive about how they're going to do it. My challenge back would be that we need to be doing Home First. We need to be outreaching and supporting our community colleagues and being part of that bigger nirvana that Kerry talks about. I don't know if other people have thoughts about that and that role, because, you know, in acute trusts, we talk about bringing length of stay down as much as possible, and actually patients going home when they're not completely well. And I think therapists are absolutely great problem solvers to drive that. So, Liz, did you have thoughts? So Liz is having a conversation at the minute, so I'll leave her to that. Interesting question, Matthew, about governance and liability. When you look into it, as long as you are asking your professionals to do what is right and within their competencies and within their scope of practice, there is no issue. I think that's one of those old sort of employment myths that's had a role for. But getting the medics on board is an interesting one. Kerry, did you have some thoughts about how you get the medics on board for Home First? Because again, that's one of Kerry's passions and is often seen disappearing onto the wards with sweeties or any other form of blackmail to get the MDT to understand Home First.
Have we got doctors on the call today?
Yes, we do. We've got Amit.
Yeah.
So you're probably best placed to answer this, but from experience, I think they're quite a difficult group of people to get hold of. So as Gina alluded to, we do tend to do lots of bribery. So Annette, one of my colleagues, and I will often go around the wards with sweets. And if we do catch some doctors, and they all wear green in this organisation, so that's quite handy, we can spot them. And we do tend to pin them against a wall. I think the way that it works here is if we can get the consultants on board, the junior doctors will follow. We've left the room, but it's not the same in all areas. So I'm hoping that Amit's now a geriatrician. I've said the right things. I'll back off. It's all gone quiet.
So absolutely, I think there is a bit of a drive around that. Does anybody else have a method of getting medics to deem people? Now interestingly, the infamous medically fit before discharge question. Amit, hi.
I was muted, but I was.
Let's say all the wrong things.
I can't see myself, but I hope you can hear me.
Yeah, we can hear you, Amit. We can hear you.
Yeah, so I was intently listening to the discussion. So thank you very much for organizing this. Firstly, right. So how do we get the doctors on board? So I think the awareness around home first and deconditioning is much more visible now as compared to what it was, let's say, 4, 5, 6 years ago. How do we get them to engage? I think there are variable levels of practice. So some are better than others. I don't think that the bribery with some sweets will work though. I think what might actually be useful is to increase that awareness that what are the harms that we are actually causing to a particular patient in terms of inappropriate rest and the scientific basis of that, i.e. the loss of muscle, the loss of circulatory volume, loss of the lung volumes, as well as the physical and mental health issues that actually go with this. And there are lots of useful materials around the deconditioning awareness and prevention campaign, which I think is commonplace for a lot of hospitals, but a lot of hospitals still need to do a lot of more stuff. But I think the other stumbling block is that there is a degree of lack of awareness of what other services, i.e. intermediate care at home, etc., are available in the community. And there is lack of linkage, the cross-working between the acute service and the community services. So the acute people may not necessarily know that an intermediate care service with rehabilitation at home exists, to how to refer, and 3, the confidence between that staff group that, well, actually, if I had close links with my intermediate care teams, they could actually take the patient and do exactly what I want them to do. So I think those are the 2 top tips: awareness around conditioning and the cost boundary working between acute and community services to provide the appropriate care at home, therapy and care.
I would agree, Amit. There's definitely a key around that cross services, cross providers conversation that helps, isn't it? In the big flow room that Kerry runs, we talk about the patient stories on a weekly basis, really in order to bring everybody to the person, bring everybody back to the patient. And we find that's the most powerful thing to do to kind of refresh our reasons. Yeah, systems, process. Yeah, we talk about those systems and the processes, but it is back to that person and what's happened to them and how can we improve that as a system that's definitely worked. I'd be really intrigued to know, Emmett, what your thoughts are with the new guidance that has come out that Liz is talking about with the DPTL and that whole shift from are they medically read or not to meet their criteria for discharge and no longer meet the criteria to reside. How are you finding selling that next step to your medical colleagues? I'd be really interested to know.
Well, I'll tell you something which is not a joke. So,
Okay.
I think the bottom line to this is, and we were discussing this even as recently as late yesterday, is that the awareness around the criteria to design is not prevalent in most places at present. And the reason why I said this is not a joke is because about 10 days, 2 weeks ago, I asked a group of my own colleagues, I said, well, have you heard of criteria to reside? And the responses I heard was related to immigration, related to visas, and right to reside because of COVID. So I think that's the level of understanding. I suspect that the information has not yet filtered down to the grassroots clinicians. And once it filters down, then we'll know exactly how the response is and how we can actually make it work.
I think we should have Liz on a national campaign on the telly, Emmett. What do you think? Telling us all, yeah, spreading, yeah, telling families, spreading the word.
Yeah.
Oh,
Liz is back.
Liz is back.
I'm not sure about that, but carry on.
I'm all right. I'm all right. Yeah, definitely. There's some great comments and practices and innovations in the chat, so we will try and pull those through as well, which would be really helpful.
On the call, just from North
Yes,
Keys.
yes, he is. I have seen Phil in the comment box.
Jill, not
Oh,
Phil.
Jill. I haven't seen Jill yet. Although I love John Woods is just put in the chat box, Liz TV, exclamation mark, Liz. So I haven't seen.
People actually see me walking around.
No, because I discreetly pull the phone back when you do that, Liz.
No, just to say to the world, we are in the middle of moving into a new house. It's real home first going on here.
He's Jim. Yeah.
Right, I'm looking for next question, Terry. Is there another question to prompt us in a bit more thought? What we think?
Yes, I'm interested on partly you've been talking about how medical staff react to this, how community staff react to the acute initiating this, and it seems to me that that setting up and running a successful home first service really takes a unique set of skills. So how do you develop and support or have some kind of network to support people on this journey to setting up and further developing their home first service? Because I think for the system leaders and staff, this is challenging, isn't it, to say the least? And so I'm sure you've probably got some kind of maybe network or the way in which you support each other to be able to develop these services.
I'm going to persuade Kerry back on camera because I think that this has been Kerry's life for the last four years now, and yeah, I think you have to try that.
Yeah, I can try. I mean, I can only ever talk from what we've done. I'm sure people are much more experienced than I am with doing these things. We basically just started with the easy wins. That's how we did it. So we took people home that we knew were not going to need a lot of support when they got there. And we did lots of sort of what we call bridging the gap. So when we started doing active recovery, we knew that we would only be supporting somebody, in theory, it was for up to 7 days, sometimes a little bit longer. And sometimes they didn't even need 7 days. So I think we just took it in. I think the thing about AHPs is that we're pretty good at problem solving and risk taking as a breed. And if you know the patient that's in front of you, it's not difficult to then have a go at managing the same things at home. And you're doing the same thing. You're just doing the same thing in somebody else's home rather than in a hospital. And in many ways, that's easier. But it feels more scary when you start because you have this what if it goes wrong thing. And I think we just ended up saying, well, if it goes wrong, the patient comes back into hospital. And that's the worst thing happens. And the person just comes back into hospital again. And then we have another go and work out what we did wrong. And it's that iterative learning thing, isn't it? It's you give it a go and then you gain a bit of confidence and you do it a bit more. but other people that have done it, I'm not sure how you started.
How did you persuade the community colleagues, or the team, not just the community, the wider team, to get on board? So how did you balance that new clinical challenge with the professional and the linking in? How did you gather your team of followers?
I think it was down to patient stories, really. It was down to showing that it's all the things that we now know, but don't forget this was about 4 years ago and it wasn't really being spoken of. But the fact that people staying in hospital for long periods of time, it's not in somebody's best interest to be in hospital waiting for a service. It's in their best interest to be at home and probably not even needing what you think they need at home. So it was down to looking at lengths of stay. It was down to looking at what's happening to people in hospital. It was looking at people that we knew should have had the opportunity to go home and sadly didn't go home. Yeah, it was talking about the patients, really, getting people on board with understanding you're talking about people and people's lives. And hospital shouldn't be the thing that breaks you. Hospital should be the thing that makes you better. And then you can go home and recover fully from whatever is wrong with you, fingers crossed, so long as that's something that's possible. I think it was, yeah, talking patients we did it really in the end. Because that's what we're here for, isn't it, at the end of the day? We're all trying to do the right thing. Sometimes not doing the right thing, but I truly believe nobody goes to work to do the wrong thing. It's just working out what the right thing is.
Yeah, I would agree. And I think from your network question, Terry, I think we have had lots of support from Liz and from Liz's colleagues in what was eSyst and now NHSI and E. I think using the Sheffield Flow system really helped. It really helped those honest conversations that brought down a lot of barriers across the system. I noticed Karen was putting a comment in about getting that commitment and restarting and realigning is challenging. Absolutely. Would I be honest if I sat here saying it's been really easy to do? Absolutely not. But has it been a journey that kind of recurs your faith in the NHS and social care? Absolutely. And I think it is a system where there are mutual benefits for the NHS and social care. So if we get Home First right, we know that patients do not need so much care. They get the best chance of the best outcome. And I think sat here with my kind of manager hat on, that's been the way I've gone about kind of selling that as a system ask. And I think that's worked better that way, trying to share the objective, I think. Does that answer your question, Terry?
It does, and my simple mind is then thinking, okay, I want to position this to other people. I want to be able to position this within my specialty. And people always ask why. So can you maybe give me some important whys to Home First? Why is Home First something that the principle of we should be looking to spread as widely as we possibly can to impact on other discharge pathways? So tell me your whys, please.
So I'm going to give you my why, and then I'm going to get Kerry to do the same. And then if Emily and others and Emmett are up doing the same, I think we should all share our why, because they're really quite powerful, aren't they? So I will tell you a story about my mum-in-law, who effectively got trapped in hospital at the age of 91 with a really nasty tibial plateau fracture. She'd had several fractures before. She was osteoporotic, but at that point was still driving her car, so was really quite mobile and quite independent. The battle that it took to get her out of an acute trust that will remain nameless but not local to here, and the impact that I saw on her and the wider family really hit the chord with me. And as a physio, I was quite perplexed, really couldn't work out why we were not and she through a trial, an almost literal arm twisting, we managed to get her out on a supported trial, which we now would all recognise as Home First. And in fact, she became our poster girl for what we did here at Bath. So for me, I've got very personal reasons. I've seen it work, and I've also seen the impact or the risk of what would happen if it didn't. So that's my why. Emmett, you were on the screen. Did you want to do your why, and then I'll ask Kerry and others? I think I might have lost Emmett again. Kerry, in the meantime, give me your why, and then we'll see if Liz is. I think Liz is walking about doing something at the minute, and then we'll get Liz's why. So Kerry, come on. Oh,
she's
yeah,
there. She's there.
So let's get Liz's why, and then I'll get Kerry's.
My why is very similar to Gina's, and I think people who've watched Doug's story, the video that we did, which is on the ESIS Futures platform, it's about actually allowing people who really, really want to go home to be home. And it's particularly, that's why I was asking if Jill was able to speak, because I think the experience in North Tees has been that it's people with dementia and delirium that it really, really benefits. In hospital, they will not be able to show you how well they do. And my why has now become a husband that was diagnosed with Alzheimer's last week, so I need no stronger why than that.
Thank you, Liz. Kerry? I'm trying to move back my 2 meters and keep Liz in the screen. I tell you, I'm having my workout this morning. It's going great.
I'll hold you, Liz, for a bit. Is that a gentler hand? Can you feel the difference? There you go. Look at that. I think my why is just because, well, I could tell you a mother-in-law story, which would also break your heart, but she's fine now at the end of it all. But I think my why is just that people don't behave the same in hospital as they do at home. And that's my biggest why, is that we're not seeing people as they really are in hospital. We're seeing them poorly, and we're seeing them completely out of context and without the things that normally support them at home. So that's my big why, I think. It's pretty basic. Shall I carry on holding you, Liz? Is that nice?
Emmett, did you want to give us your why? We might have lost Emmett. Oh, no. Yay.
My why always comes down to one question: why do we do what we do? And if our discharging patients in time, and I'm not necessarily saying prematurely or early or late or whatever, but there is a right time for everything. And if we can do everything at the right time, first time, then if that makes the patients better, then it is our responsibility to make those systems right to achieve our why.
Lovely. Emily, Alice, thoughts?
Hello.
Hi.
I think I've seen it from both sides, working in the acute and working in ESD. And we had patients in ESD who were destined for a bed-based care setting, and we took them home. We took a risk, and we managed them through, with the help of their families, supported their families through some pretty hairy first few days, like Alice was saying. But over time, we managed to keep them at home through multiple admissions, and they ended up passing away at home, which is what they wanted. And then on the flip side of that, I've had patients since then who, when there hasn't been capacity in the system, have missed their window and then deconditioned, fallen over, and ended up passing away in hospital. And when you see it both sides, you see the risks of the hospital admission and how dangerous it can be for people to stay here too long. Whereas when you get them out at the appropriate time, even if that is a risky situation, it's normally less risky than staying put in hospital.
I think you touched on a really good point there, Emily. And I'll give Alice a chance to give her why in a second as well. And then I might get Kerry to tell us a couple of stories about her Home First Delirium Service, another trial that we've set up, because we're really keen that anyone has access to Home First. As Liz often says, it's not about which type of patient can access Home First. Everyone should have that opportunity. But first, Alice, did you want to give us your why?
Yeah, I think what has already been touched on, I think the cognitive thing is massive. I think I remember taking a patient home who was really aggressive, in the hospital, and we were a bit worried about taking her in the car actually and things like that, but it was fine. And when she was home, she was a totally different person. And as you kind of mentioned, Emily, you know, that kind of person could have ended up in a nursing home or something like that, and it was just completely unnecessary. But without actually physically taking her home, you can't see that in the hospital. So I think those kind of things are so important, and it's very difficult to see if you're just in the acute.
Definitely. Kerry, did you want to give us a couple of the examples with your home first patients with delirium, because that was quite an interesting challenge. I'll hold Liz for a minute.
Disappeared again. So yeah, we started to look at taking some patients home who had ongoing delirium. And in order for that to happen, we knew that we probably needed some overnight support. We weren't quite sure how we were going to access that. I know Liz has said that there's lots of live-in care at home. At the time that we were doing it, and particularly in this area, there wasn't actually any live-in care at home. So we had to try and devise a way of doing it. And we settled on, in the end, 2 12-hour shifts, because that's kind of the best way of doing it. And we had enough funding to take 5 people home on the delirium pathway, and we discovered, to nobody's surprise, that within about the first 72 hours of being at home, the delirium settled. And if it wasn't going to settle at that point, then we knew there was something a little bit more to it, not just a delirium. So we took 5 patients home. These people, we had 2 people that actually came back in and died in hospital because they were really quite unwell people. I think the thing to remember when you're dealing with somebody with a delirium is that you're dealing with somebody that's often either very frail or really quite unwell. So we weren't expecting all of these people to get better. What we were hoping was that taking them home was going to make a difference, and it did. So now we work with our colleagues in Bath and North East Somerset, and I'm really happy to tell you they now have an overnight service available. So I've got a gentleman at the moment who we're hoping to take home with some overnight support and just see if we can get him to settle at home. So it's available now, which is great.
So interestingly, Becky's put a question in the chat about any advice from people that have done home first. Night needs as a tool for, or assessment, if people can manage at home. This results in a lot of time. We've had that challenge previously, haven't we?
Yeah. Because the thing is, I think that we create night needs in hospital. We create night needs because the lights tend to be on the wards, or it's a bit noisy, and the bed's probably not very comfortable. And if you're a light sleeper and you haven't got your earplugs and your eye mask, or you didn't think to bring it in, or you have some cognitive impairment, I think we create night needs. We then go and help people to the toilet when perhaps they don't need help, and then suddenly we've got people with night needs that they probably haven't got, which means they can't go home. So, and certainly with our delirium group, that was quite a big deal, because if you've got somebody that's really quite active at night, there's that thought they might leave the house. And they probably won't, but you don't know that until you've actually taken them home and kind of, proven that it's not going to happen. So that's what we did.
And Kerry, with that use of assistive technology is really helpful in when people don't wander out, and we need to get much better at doing that. You can make people very safe at home.
Yeah,
with all now available.
Completely agree.
Absolutely. I'm mindful, everybody, we're down to the last 5 minutes, and I just wondered, Liz, if there was anything particularly you wanted to get across in the last 5 minutes, or ask of us, or challenge us all to think about home first going forward.
So I know it's difficult, but we have got the money. If you are finding there are blockers coming back into systems, frankly, that needs escalating, and preferably all the way up to us in the centre, because we're able to ask questions. There shouldn't be anybody worrying about money at the moment. I would urge people not to buy beds with the money, apart from the COVID positive discharge beds.
Hallelujah.
You're going to have to buy, but they are tiny numbers. When we were looking, it's about 35 discharges a day across the country. So you aren't going to be buying large numbers of beds for COVID positive older people that have come in from a care home and can't go back to that care home. And really, I think it's like my many friends I've asked to be part of this call. It does require people to be brave. This is different. And I'd really like to know what would need to be different to help people be that brave. and really, really put people at the centre. The stories of these delirium and dementia patients that go home and are no longer aggressive are really powerful. And, you know, just moving somebody into a different environment who has dementia or delirium means they won't be able to find the loo at night. They haven't a hope in hell in hospital. So the 72-hour acute frailty pathways, and even preventing them coming in if at all possible, mustn't be forgotten in this. The money can be used for urgent community response for the first 48 hours. So please, 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 everybody, give it a go. And we're here centrally if people want support. We work closely with the LGA and the Better Care Fund team, and we can provide support at all levels within systems. So go for it, please, guys.
Thank you, Liz. Terry, any other questions or thoughts for the last 3 or 4 minutes?
No, I think this is really, really inspiring. It's when we all reflect on either personal family situations or situations we've experienced at work, we can all relate to why this is so important, that home first has to be impacting not just on the discharge planning and care for older people. As Liz said, everybody should have the opportunity to go home first. And so this has just inspired me even more to think and work with my stoma care nurse colleagues to think, how can we ensure that somebody who's in hospital, had stoma formation surgery, how can we get them home quicker with the follow-up and support and the digital technology that we can do at home? So it's all about promoting independence, not dependence on me as a nurse specialist. So I'm sure many people from many different specialties will have learnt from this and will be applying this thinking to their area of work. So Liz, I thank you for this amazing legacy, actually, that is rippling across the whole of health and social care. Thank you very much. Yeah,
Harry, very, very brilliant.
Thank you. Okay.
Great. Terry, what we will do, I'll put out on a Twitter after this, because I've only got one hand free now and my Twitter device is in my other hand with our lovely Liz. I will, with your permission, Liz, sharing your email address on that, Kerry's email address, and others from here. So if there is anybody that's wanting that extra support, or we can get that ball rolling in any other way we need to. I know on some of you on the call, AHPs will be part of the AHP forum and that Suzanne Rastrick set up. I know our colleague Lee is setting up a post-DPTL Home First discussion group on there as well, Liz. So I'll dig that link out and get that out in a tweet as well for people.
Brilliant.
So we will do that. So massive thank you, Liz, for tolerating the WhatsApp link and the tech with us today. And thank you to everybody for your comments, thoughts and chat.